Let's start out with the fundamental functions of the lungs. The respiratory system is organized into two main zones, the conducting zone and the respiratory zone. Each of these zones has its own distinct role that collectively enables ventilation and gas exchange. First, the conducting zone. This zone consists of structures that serve as passageways for air to enter and exit the lungs. However, they are not directly involved in the exchange of gases between the air and blood. Instead, the conducting zone's primary function is to filter, warm, and moisten incoming air, preparing it for gas exchange. Key structures here include the trachea, bronchi, and larger bronchioles. The respiratory zone is where the actual gas exchange occurs. This zone includes the respiratory bronchioles, alveolar ducts, and alveoli. These structures are designed for the diffusion of oxygen and carbon dioxide between the air in the lungs and the blood in the pulmonary capillaries. Let's look at the general form of the lungs. Each lung has a conical shape that is rounded at the top and wider at the bottom. This shape supports maximal lung capacity while allowing the lungs to fit comfortably within the thoracic cavity. Inferior to the lungs is the diaphragm, which is the primary muscle involved in ventilation. The diaphragm forms the base of the thoracic cavity and separates it from the abdominal cavity. During inhalation, it contracts and flattens, creating a negative pressure that draws air into the lungs. Its role is absolutely necessary for efficient ventilation as it drives the bulk of the respiratory movement. The apex of each lung is the topmost part, extending just above the first rib and slightly above the clavicle. This area is important as it sits close to major blood vessels such as the subclavian arteries and veins. At the opposite end, you have the base of the lungs, which rests on the diaphragm. The concave shape of the base of the lung allows it to fit snugly against the diaphragm, which is slightly higher on the right side due to the liver sitting beneath it. When comparing the right lung versus the left lung, there are several appreciable anatomical differences. The right lung is slightly larger and divided into three lobes, the superior, middle, and inferior, whereas the left lung only has two lobes, the superior and inferior. This asymmetry exists because the heart is located slightly to the left, reducing the available space on the left side of the thorax. To accommodate the heart's position, the cardiac notch is present on the left lung. This is a concave indentation on the medial side of the left lung that allows room for the heart. The cardiac notch is a great example of the unique fit of organs within the thoracic cavity, where each structure is adapted to function alongside other neighboring organs. The lungs are further divided into bronchopulmonary segments. These are subdivisions within each lobe, each segment supplied by its own tertiary bronchus and blood vessel. This segmentation allows for greater control of ventilation and blood flow within the lungs. From a surgical perspective, specific bronchopulmonary segments can be removed or treated independently, preserving as much lung function as possible. Surrounding the lungs are the pleura, which help keep the lungs inflated and lubricated, ensuring their smooth operation. The visceral pleura is the inner layer of the pleural membrane, which is tightly adhered to the surface of the lungs. The visceral pleura covers each lung and follows all of its contours, including the fissures between lobes. The parietal pleura is the outer layer of the pleural membrane, which lies the inner surface of the thoracic cavity, the diaphragm, and the mediastinum. It creates a protective compartment around each lung. Production of pleural fluid occurs between the visceral and parietal pleura within the pleural cavity. This fluid reduces friction as the lungs expand and contract, facilitating smooth respiratory movements within the thoracic cavity. Compartmentalization by the pleura helps isolate each lung within its own cavity. The separation provides protection. If one lung collapses or is injured, the other lung can continue functioning independently within its own pleural cavity. The pulmonary artery is the main vessel supplying deoxygenated blood from the right side of the heart to the lungs. It branches extensively within the lungs, running alongside the bronchial tree, and ultimately divides into smaller vessels that reach the pulmonary capillary surrounding the alveoli. Pulmonary lobules are small functional units of the lungs, each supplied by its own branch of the pulmonary artery, ensuring that deoxygenated blood reaches these areas of gas exchange. The pulmonary capillary network forms a dense netting of capillaries surrounding each alveolus. This proximity to the alveoli allows for the rapid exchange of gas, with oxygen diffusing into the blood and carbon dioxide diffusing out. Pulmonary veins collect oxygenated blood from the pulmonary capillary network and return it to the left atrium of the heart. Unlike the systemic veins, which usually carry deoxygenated blood, pulmonary veins carry oxygen-rich blood, which is then pumped out to the rest of the body to meet its metabolic demands. The root is the superior attachment point of the nose located between the eyes. It serves as the structural foundation for the external nose. The bridge forms the bony upper part of the nose, providing structural support and shape. It is primarily formed by the nasal bones. The dorsum nasi is the length of the nose, extending from the root to the apex, creating the central ridge of the nose. The nares, or nostrils, are the external openings of the nasal cavity, allowing for the intake of air and the passage of respiratory and olfactory substances. Cartilage within the nose provides structure while allowing flexibility. The lateral, alar, and septal cartilages form the framework of the nasal tip and support the nares. The nasal conchae are bony projections within the nasal cavity that increase the surface area, helping to warm, humidify, and filter the incoming air. In addition to the nasal cavity, the respiratory system includes a set of air-filled cavities known as the paranasal sinuses. These sinuses are located within the bones of the skull and play several supportive roles in respiratory function. By producing mucus, the sinuses help to trap particles and moisten the air entering the respiratory tract. Additionally, they lighten the weight of the skull and contribute to the resonance of our voice. Each sinus has a unique location and function, which we'll review in brief. The frontal sinuses are located in the frontal bone, just above the eyebrows. The maxillary sinuses are the largest of the paranasal sinuses and are located in the maxillary bones on either side of the nose. The sphenoidal sinuses are located within the sphenoid bone, deep in the skull behind the nasal cavity. The ethmoidal sinuses consist of multiple small air cells within the ethmoid bone, located between the nose and eyes. The pharynx, commonly referred to as the throat, serves as a shared passageway for air, foods, and liquids, connecting the nasal and oral cavities to the larynx and esophagus. The pharynx is divided into three distinct regions, each with its own specific functions. The nasopharynx is the uppermost part of the pharynx, located posteriorly to the nasal cavity. It serves solely as an air passage and is lined with ciliated epithelium to help filter and trap airborne particles. The nasopharynx also contains the pharyngeal tonsils, which are part of the immune system and help defend against pathogens entering through the nose. The oropharynx is the middle portion of the pharynx, located posterior to the oral cavity. This segment serves as a pathway for both air and ingested materials, making it part of the respiratory and digestive systems. The oropharynx is lined with a more protective type of epithelium to handle the abrasion from food and liquids passing through it. The laryngopharynx is the lowest portion of the pharynx, connecting to the larynx anteriorly and the esophagus posteriorly. This area directs food and fluids towards the esophagus while allowing air to pass into the larynx. The laryngopharynx ensures that food does not enter into the respiratory tract by aiding in the closure of the larynx during swallowing. Let's take a look at the larynx in a bit more detail. The larynx is composed of several cartilage structures that provide both support and flexibility. The thyroid cartilage is the largest cartilage of the larynx and forms the prominent anterior projection known as the Adam's apple. It serves as a protective shield for the vocal cords and other internal structures within the larynx. The epiglottis is a leaf-shaped flap of cartilage located at the entrance of the larynx. Its primary function is to prevent food and liquid from entering the airway during swallowing. When we swallow, the epiglottis folds down to cover the glottis, directing food and fluids towards the esophagus instead. The cricoid cartilage is the only complete ring of cartilage in the larynx and is situated below the thyroid cartilage. It provides structural support and connects the larynx to the trachea, helping maintain an open airway for respiration. The arytenoid cartilages are paired, pyramid-shaped cartilages that play a key role in vocal cord movement. They allow for the opening and closing of the vocal cords, essential for producing sound as well as protecting the airway during swallowing. Now that we've examined the larynx, let's look at the glottic opening specifically. The glottis refers to the vocal apparatus, which includes the vocal cords and the opening between them. It acts as a valve that can open widely for breathing or close tightly to protect the airway, especially during swallowing. By adjusting the tension and position of the vocal cords, the glottis plays a key role in phonation, as well as in regulating airflow into the lower respiratory tract. The true vocal cords, also known as the vocal folds, are elastic bands of tissue within the glottis that vibrate to produce sound when air passes through them. The pitch and volume of the sound are determined by the tension and position of these cords, which are controlled by the laryngeal muscles. The vestibular folds, or false vocal cords, are located above the true vocal cords. They do not contribute to sound production, but help close the larynx when swallowing, providing an additional layer of airway protection. The cuneiform and corniculate cartilages are small cartilaginous structures associated with the glottis. They provide support and help stabilize the laryngeal structures. They contribute to the flexibility and control required for both phonation and airway protection. Inferior to the glottis lies the trachea, which is a tubular structure that serves as the primary airway, conducting air between the larynx and the bronchi. Approximately 4 to 5 inches in length and about an inch in diameter, the trachea is lined with ciliated epithelium and mucus-producing cells, which work to filter and trap particles from inhaled air. The trachea's structure is specialized to maintain an open airway while allowing some flexibility for head and neck movements. C-shaped rings of cartilage support the trachea, providing rigidity to prevent collapse while also allowing flexibility. These incomplete rings face posteriorly, with the open part of the C positioned toward the esophagus, allowing the trachea to expand slightly as we inhale, while also accommodating the esophagus when swallowing large boluses of food. The trachealis muscle spans the open posterior side of the C-shaped cartilages. This smooth muscle can contract or relax to alter the diameter of the trachea, controlling airflow. During coughing, the trachealis muscle contracts to narrow the trachea, increasing airflow speed to expel irritants more effectively. The carina is the point where the trachea bifurcates, or splits into the primary bronchi, which lead into each lung. Located at the level of the fifth thoracic vertebra, the carina is highly sensitive and triggers a strong cough reflex if irritated. This is a protective mechanism to prevent foreign particles from entering the lower respiratory tract. The mucociliary escalator is an important feature of the trachea's lining. Goblet cells produce mucus that trap particles and pathogens, while the cilia move this mucus layer up toward the pharynx, where it can be swallowed or expelled. This escalator-like system is important for keeping the lower respiratory tract clean and free of obstruction. The lining of the respiratory tract is composed of different types of epithelial tissues and specialized cells depending on the region. One of the most important specialized cells found throughout the respiratory tract are goblet cells. Goblet cells are specialized epithelial cells within the respiratory tract that play a major role in airway protection. Let's break down their main functions and associated structures. Goblet cells are responsible for the continuous production of mucus, a thick and sticky secretion that lines the respiratory tract. This mucus traps particulates and pathogens, serving as the first line of defense by preventing foreign materials from reaching sensitive areas within the lungs. Surrounding the goblet cells are cilia, small hair-like projections on the surface of the respiratory epithelium. These cilia move in a coordinated fashion to propel mucus upward toward the pharynx, where it can be swallowed or expelled. This ciliary action is the bronchi are the major air passages that branch from the trachea and lead into each lung. Their primary role is to conduct air to and from the lungs, progressively branching into smaller and smaller passages to distribute air throughout the lung tissue. The primary bronchi are the first branches off of the trachea, with one bronchus directed toward each lung. The right primary bronchus is wider, shorter, and more vertical than the left, making it more susceptible to foreign object entry. Each primary bronchus supplies air directly to its respective lung. The secondary bronchi, also called the lobular bronchi, branch from each primary bronchus to serve the individual lobes of each lung. The right lung has 3 secondary bronchi for its 3 lobes, while the left lung has 2. The tertiary bronchi, or segmental bronchi, branch from the secondary bronchi and supply air to the bronchopulmonary segments. Each segment can function somewhat independently, which is useful clinically as it allows for targeted interventions or resections without affecting the entire lung. The tertiary bronchi further divide up into the bronchioles. The bronchioles are smaller branches that lack cartilage and are primarily made up of smooth muscle. These smaller passages can constrict or dilate to regulate airflow into the alveoli, a process controlled by the autonomic nervous system. The terminal bronchioles are the last portions of the conducting zone where air is filtered, warmed, and humidified. Beyond the terminal bronchioles lies the respiratory zone where gas exchange begins. The alveoli are located at the ends of the smallest bronchioles. They are the primary sites for gas exchange, with thin walls that allow oxygen and carbon dioxide to diffuse between the air and blood. The alveolar ducts are small passages that lead from the respiratory bronchioles to the clusters of alveoli. They distribute air to the alveolar sacs and contribute to the final stages of air passage before reaching the alveoli. The alveolar sac is a cluster of individual alveoli that shares a common opening. This organization allows for a large surface area within a small volume, optimizing the space for gas exchange within the lungs. Each alveolus is lined with a thin epithelial layer, specifically designed to allow rapid diffusion of gases. The walls are highly vascularized, surrounded by a network of capillaries that facilitate the transfer of oxygen and carbon dioxide between the alveoli and bloodstream. The alveolar pores, also known as pores of Kohn, are small openings between adjacent alveoli that allow for collateral ventilation. The structure helps equalize air pressure across the alveolar sacs and provides an alternate pathway for airflow if certain passages become obstructed. Alveoli are made up of 2 main cell types, which are assisted by a unique type of immune cell. Type 1 cells are thin, flat epithelial cells that form the majority of the alveolar wall. These cells create the thin barrier necessary for efficient gas diffusion between the air and blood. Type 2 cells are specialized cells within the alveolar walls that produce surfactant, a substance that reduces surface tension, preventing alveolar collapse during exhalation. Surfactant is important for maintaining alveolar stability and proper lung function. The alveolar macrophages are immune cells located within the alveoli. They patrol the alveolar surface, engulfing and removing inhaled pathogens, particles, and debris, helping to keep the lungs clean and reducing the risk of infection. Alveolar gas exchange is the process by which oxygen and carbon dioxide are exchanged between the alveoli and the blood in the pulmonary capillaries. This exchange relies on partial pressure gradients and the properties of the alveolar capillary membrane. Surface tension within the alveoli is created by the thin layer of fluid lining the alveolar walls. This tension, if left unregulated, would cause the alveoli to collapse. To counteract this, alveolar cells produce surfactant, which lowers surface tension and keeps the alveoli open. Surfactant is a lipoprotein substance produced by type 2 alveolar cells. It reduces the surface tension, allowing the alveoli to expand easily during inhalation and preventing collapse during exhalation. Without adequate surfactant, as seen in premature infants, the lungs struggle to stay inflated. Compliance refers to the lung's ability to stretch and expand. High compliance makes it easier for the lungs to inflate, while low compliance, found in conditions like pulmonary fibrosis, increases the work of breathing. Lung compliance affects the ease of gas exchange by determining how readily the alveoli can expand and fill with air. Ventilation is the process of moving air in and out of the lungs, enabling gas exchange between the atmosphere and the bloodstream. This process depends on changes in pressure within the thoracic cavity, which drive airflow based off of pressure gradients. Atmospheric pressure refers to the pressure exerted by the weight of the air outside of the body. At sea level, this is approximately 760 millimeters of mercury. Atmospheric pressure is the baseline we use to measure pressures within the lungs. Intrapulmonary pressure, also known as alveolar pressure, is the pressure within the alveoli of the lungs. During inhalation, the intrapulmonary pressure falls below atmospheric pressure, allowing air to flow into the lungs. During exhalation, it rises above atmospheric pressure, causing air to flow out. Intrapleural pressure is the pressure within the pleural cavity, typically lower than both atmospheric and intrapulmonary pressures. This negative pressure helps keep the lungs expanded by creating a suction effect. If intrapleural pressure becomes equal to atmospheric pressure, as in cases of pneumothorax, the lung can collapse. Eupnea refers to normal, unlabored breathing, typically occurring at rest. Eupnic breathing is primarily driven by contraction of the diaphragm, which changes thoracic volume and creates the pressure gradients needed for airflow. Hyperpnea is increased breathing depth or rate, usually occurring during exercise or metabolic demand. Unlike eupnea, hyperpnea involves both the diaphragm and accessory muscles to meet the body's increased oxygen requirements. Diaphragmatic breathing is a type of breathing in which the diaphragm is the primary muscle that's engaged. This method of breathing is efficient and maximizes lung volume as it draws air deep into the lower lobes of the lungs. Costal breathing, or shallow breathing, relies more on movements of the rib cage than on the diaphragm. It is often observed during periods of pain, respiratory distress, or when diaphragm function is impaired. The mechanics of breathing are governed by physical principles that explain how air flows into and out of the lungs. These principles are based on the relationship between pressure and volume within the thoracic cavity, primarily described by Boyle's law. Boyle's law states that at a constant temperature, the pressure of a gas is inversely proportional to its volume. In the context of respiration, this means that as the volume of the thoracic cavity increases, the pressure within the lungs decreases, allowing air to flow in. Conversely, when thoracic volume decreases, pressure increases, pushing air out of the lungs. During inhalation, the diaphragm contracts and moves downward, and the intercostal muscles elevate the rib cage, expanding the thoracic cavity. This increase in volume decreases intrapulmonary pressure, creating a negative pressure relative to atmospheric pressure, which draws air into the lungs. Exhalation is typically a passive process where the diaphragm and intercostal muscles relax, causing the thoracic cavity to decrease in volume. This volume reduction increases intrapulmonary pressure, pushing air out of the lungs as it becomes higher than atmospheric pressure. Pressure gradients drive the flow of air in and out of the lungs. For air to enter the lungs, intrapulmonary pressure must be lower than atmospheric pressure. For air to exit, intrapulmonary pressure must exceed atmospheric pressure. These gradients are important for continuous ventilation. The elasticity of the lungs and the compliance of the chest wall influence the ease of breathing. Elastic recoil of lung tissue aids in exhalation by returning the lungs to their original shape, while lung compliance describes how easily the lungs can expand. Higher compliance allows for easier inflation, while lower compliance, as seen in restrictive lung diseases, makes breathing more labor-intensive. Gas exchange in the lungs relies on principles of physics that govern the movement of gases across the respiratory membrane. These principles are based on the behavior of gases under different conditions and their partial pressures, which determine the direction and efficiency of gas diffusion. Pulmonary ventilation refers to the movement of air into and out of the lungs, ensuring a continuous supply of oxygen and removal of carbon dioxide. Proper ventilation maintains a concentration gradient between the alveolar air and the blood in the pulmonary capillaries, which is important for gas exchange. Partial pressure is the pressure exerted by a single gas within a mixture of gases. In the context of respiration, Oxygen and carbon dioxide move across the alveolar capillary membrane according to their partial pressures. Oxygen diffuses into the blood where its partial pressure is lower, while carbon dioxide diffuses out of the blood where its partial pressure is higher. The total pressure of a gas mixture is the sum of the partial pressures of all gases within that mixture. In atmospheric air, oxygen, nitrogen, carbon dioxide, and other gases contribute to the total pressure. The partial pressures of these individual gases influence their diffusion rates in the lungs. Dalton's law states that each gas in a mixture exerts pressure independently of the others. This principle allows for calculating the partial pressure of each gas based on its concentration within the mixture, which is important for understanding gas exchange dynamics. The last gas law we should be familiar with is Henry's law. Henry's law explains how the solubility of a gas in a liquid is proportional to its partial pressure. This law helps describe how oxygen and carbon dioxide dissolve into the blood. Oxygen has a lower solubility in blood compared to carbon dioxide, requiring hemoglobin for efficient transport, whereas carbon dioxide readily dissolves and diffuses out of the blood. Respiratory volumes and capacities measure the amount of air moving in and out of the lungs during different phases of the respiratory cycle. These measurements provide valuable information on lung function and respiratory health. Tidal volume is the amount of air inhaled or exhaled during a normal breath while at rest. This volume varies with activity level, increasing with exertion and decreasing with rest. The expiratory reserve volume is the additional air that can be exhaled forcefully after a normal exhalation. ERV reflects the reserve capacity of the lungs during more forceful breathing. The inspiratory reserve volume is the extra amount of air that can be inhaled forcefully after a normal inhalation. The IRV represents the additional volume available during times of increased oxygen demand, such as exercise. Residual volume is the amount of air remaining in the lungs after a forceful exhalation. This volume prevents lung collapse and maintains continuous gas exchange between breaths. The total lung capacity is the maximum amount of air that lungs can hold, calculated as the sum of all lung volumes. The total lung capacity varies with age, sex, body composition, and health status. Vital capacity is the total amount of air that can be exhaled after a maximum inhalation. It's a key indicator of lung capacity and overall respiratory health. Inspiratory capacity is the maximum volume of air that can be inhaled after a normal exhalation, combining tidal volume and inspiratory reserve volume. The functional residual capacity is the volume of air remaining in the lungs after a normal exhalation. The functional residual capacity helps keep the alveoli open and maintains baseline lung volume. Anatomical dead space refers to the volume of air that fills the conducting zones but does not participate in gas exchange. This includes the air in the trachea and bronchi, where air remains unused. Alveolar dead space represents areas within the respiratory zone where alveoli are ventilated but not perfused, thus not participating in gas exchange. This can occur in certain lung conditions where blood flow to some alveoli is restricted. The total dead space is the sum of anatomical and alveolar dead space, representing the portion of inspired air that does not contribute to gas exchange. Minute ventilation is an important parameter for assessing respiratory efficiency and is often used in both clinical and research settings. The calculation of minute ventilation is straightforward. It's the product of tidal volume, or the amount of air inhaled or exhaled during a single breath, and respiratory rate, or the number of breaths taken per minute. In a typical adult at rest, the tidal volume is approximately 500 milliliters per breath, and the respiratory rate is about 12 to 20 breaths per minute. This would result in a minute ventilation of 6 liters per minute. However, these values can vary significantly based on a multitude of factors, including physical activity, age, body size, and health status. Minute ventilation is particularly important in clinical medicine, especially in patients with respiratory disorders like COPD or asthma, or in those requiring mechanical ventilation. In these situations, minute ventilation can be adjusted by changing either the tidal volume, the respiratory rate, or both to optimize gas exchange and reduce the work of breathing. For example, in mechanical ventilation, settings are often adjusted to maintain adequate minute ventilation while avoiding lung injury caused by excessive volumes or pressures. In a physiological context, minute ventilation increases during exercise or any condition that raises metabolic demand. This increase ensures that the body's increased oxygen requirements are met and that the additional carbon dioxide produced is effectively removed. Nervous innervation of the lungs is important for regulating breathing patterns, airway resistance, and bronchial tone. This innervation is controlled by both the parasympathetic and sympathetic branches of the autonomic nervous system, as well as specific respiratory centers in the brain. The parasympathetic nervous system primarily influences bronchoconstriction, which narrows the airways. This effect helps reduce airflow and conserve energy when the body is at rest. Parasympathetic stimulation also increases mucus production, aiding in the filtration and humidification of inhaled air. The sympathetic nervous system promotes bronchodilation, widening the airways to enhance airflow. This is especially important during physical activity or stress, when increased oxygen intake is necessary. Sympathetic stimulation also decreases mucus production to reduce airway resistance and facilitate faster airflow. The vagus nerve provides parasympathetic innervation to the lungs, playing a central role in reflexive airway responses. For example, the vagus nerve helps mediate the cough reflex, which protects the lower respiratory tract from foreign particles or irritants. The medullary respiratory center in the brainstem controls the basic rhythm of breathing. This center includes the ventral and dorsal respiratory groups, which coordinate the rhythmic contraction of respiratory muscles to maintain steady ventilation. The ventral respiratory group contains neurons responsible for both inspiration and expiration. It is particularly active during forceful breathing, such as exercise or respiratory distress, when increased ventilation is required. The dorsal respiratory group is primarily involved in controlling inspiration and receives sensory input regarding blood gases and lung stretch. The dorsal respiratory group processes this information and adjusts the breathing rate to maintain homeostasis. The pontine respiratory group in the pons fine-tunes the rhythm of breathing and modulates transitions between inhalation and exhalation. It contains the apneustic and pneumataxic centers, which help smooth respiratory patterns. The apneustic center promotes prolonged inspiration by stimulating the respiratory neurons in the medulla. This center can create a deeper inhalation, especially when oxygen demand is increased. The pneumataxic center acts as a brake on inspiration, inhibiting the apneustic center to allow for controlled, rhythmic breathing. By limiting inhalation, it ensures smooth transitions to exhalation. Respiratory rate is an important physiological parameter that reflects the body's demand for oxygen and the need to expel carbon dioxide. Respiratory rate is closely regulated by several factors to maintain homeostasis. CO2 levels in the blood are the primary driver of respiratory rate. When CO2 levels rise, blood becomes more acidic due to the formation of carbonic acid. Chemoreceptors in the medulla and carotid bodies detect this increase and stimulate the respiratory center to increase the rate and depth of breathing, expelling CO2 to restore normal pH levels. pH levels of the blood also influence the respiratory rate. A decrease in blood pH, known as acidosis, triggers an increase in breathing to remove excess CO2 and restore balance. Conversely, alkalosis, an increase in blood pH, can reduce the respiratory rate as the body attempts to retain CO2 to normalize pH levels. O2 levels are detected by peripheral chemoreceptors in the carotid and aortic bodies. Although CO2 levels are the primary respiratory stimulus, low oxygen levels can also increase the respiratory rate, especially when O2 levels drop significantly. This response is important at high altitudes or during respiratory compromise. Ventilation and perfusion work together to ensure efficient gas exchange within the lungs. Ventilation refers to the movement of air into and out of the alveoli, while perfusion refers to the blood flow through the pulmonary capillaries. For optimal oxygenation, these processes must be closely matched. Ventilation involves the distribution of air into the alveoli. Factors such as airway resistance, lung compliance, and body position can influence the amount of air reaching different parts of the lung. Perfusion refers to the flow of blood to the alveolar capillaries, allowing oxygen to enter the blood and carbon dioxide to be removed. Perfusion depends on cardiac output and pulmonary blood pressure, which can vary with body position, gravity, and vascular resistance. The ventilation to perfusion ratio is a measure of the relationship between the amount of air reaching the alveoli and the blood flow in the surrounding capillaries. An ideal VQ ratio is approximately 0.8, meaning ventilation is slightly less than perfusion under normal conditions. Disruptions in this ratio can lead to inefficient gas exchange. VQ mismatch occurs when ventilation and perfusion are not evenly matched, leading to areas of the lung where gas exchange is impaired. A high VQ ratio indicates ventilation exceeds perfusion, as seen in conditions like pulmonary embolism. A low VQ ratio suggests perfusion exceeds ventilation, commonly occurring in obstructive airway diseases. Shunting describes a situation where blood bypasses ventilated alveoli, typically due to alveolar collapse or fluid-filled alveoli, leading to low oxygenation despite adequate blood flow. Shunts are a common cause of hypoxemia in conditions like pneumonia or pulmonary edema. Gas exchange is a critical function of the respiratory system. This process occurs by passive diffusion across the respiratory membrane of the lungs, relying on partial pressure gradients to drive the movement of gases. External respiration occurs between the alveoli and the blood in the pulmonary capillaries. Oxygen in the alveoli has a higher partial pressure than in the deoxygenated blood arriving from the pulmonary arteries. This gradient causes oxygen to diffuse across the thin alveolar capillary membrane into the blood. Hemoglobin molecules in red blood cells bind to oxygen, allowing it to be transported throughout the body. At the same time, carbon dioxide, which is a higher partial pressure in the blood than in the alveolar air, diffuses from the blood into the alveoli to be exhaled. The efficiency of external respiration depends on factors like alveolar surface area, membrane thickness, and the matching of ventilation with perfusion. Conditions such as emphysema or pulmonary edema can significantly impair gas exchange. Internal respiration refers to gas exchange that takes place between the systemic capillaries and the tissue. Here, the partial pressure of oxygen is higher in the blood than in the surrounding tissues, leading oxygen to diffuse from the capillaries into the cells. This oxygen supports cellular respiration, producing energy for cellular functions. Carbon dioxide, a byproduct of cellular metabolism, accumulates in the tissues, creating a partial pressure gradient that drives its diffusion from the tissues back into the bloodstream. The blood then transports CO2 back to the lungs for removal. Hemoglobin is a protein within red blood cells that plays an important role in oxygen transport. Each hemoglobin molecule contains 4 heme groups, each capable of binding one oxygen molecule. When oxygen diffuses from the alveoli into the blood, it binds to hemoglobin, forming oxyhemoglobin. This binding is reversible, allowing oxygen to be released as blood reaches tissues with lower oxygen partial pressures. Carboxyhemoglobin is a form of hemoglobin that binds carbon monoxide instead of oxygen. Hemoglobin has a much higher affinity for carbon monoxide, which can prevent oxygen from binding, leading to tissue hypoxia. This is particularly dangerous in carbon monoxide poisoning, where carbon monoxide binds tightly to hemoglobin and significantly impairs oxygen transport. The Haldane effect describes how oxygen levels influence carbon dioxide transport. When hemoglobin is deoxygenated as it releases oxygen to tissues, it more readily binds to carbon dioxide. This facilitates the pickup of carbon dioxide in the tissues and its release in the lungs, where oxygenation levels are high. Transportation of carbon dioxide in the blood occurs through 3 main forms. About 7 to 10% of carbon dioxide is dissolved directly into the plasma where it travels in solution. Roughly 20 to 30% binds to hemoglobin, forming carbaminohemoglobin. This form of carbon dioxide is carried on hemoglobin's protein structure rather than on its heme groups, allowing it to be transported without interfering with oxygen binding. The majority of carbon dioxide, approximately 60 to 70%, is transported as bicarbonate ions. In red blood cells, carbon dioxide combines with water to form carbonic acid, which quickly dissociates into hydrogen ions and bicarbonate ions. This reaction is catalyzed by the enzyme carbonic anhydrase and allows carbon dioxide to be carried in a chemically stable form. When blood reaches the lungs, this reaction reverses, releasing CO2 for exhalation. The oxygen hemoglobin dissociation curve shows the relationship between the partial pressure of oxygen and hemoglobin saturation. This curve illustrates how readily hemoglobin binds to oxygen in the lungs, where PO2 is high, and releases it into the tissues, where PO2 is lower. A left shift in the curve means hemoglobin holds on to oxygen more tightly. This shift favors oxygen loading in the lungs but reduces delivery to the tissues. A right shift reduces hemoglobin's affinity for oxygen, allowing it to release oxygen more readily. This shift supports oxygen release in tissues with high metabolic demand. Several factors influence the dissociation curve. A decrease in pH shifts the curve to the right, encouraging oxygen release, while an increase in pH shifts the curve to the left, enhancing oxygen binding. Elevated CO2 lowers pH by forming carbonic acid, which dissociates and releases hydrogen ions that decrease hemoglobin's affinity for oxygen, favoring oxygen release into the tissues. Higher temperatures, such as in active muscles, shift the curve to the right, promoting oxygen unloading. Lower temperatures shift the curve to the left, favoring oxygen retention. Produced by the red blood cells, 2,3-BPG binds to hemoglobin and lowers its affinity for oxygen. High levels shift the curve to the right, aiding oxygen release, especially in conditions like chronic hypoxia, high altitude, and anemia.